This patient had a severe ocular trauma a couple of years ago. He had subsequently been submitted to a penetrating keratoplasty and also to a phaco surgery. Now he has been referred to us to do an iris fixation of the IOL, since it has completely dislocated to the anterior chamber, as we can see in this UBM scan. Our goal here is to reposition the IOL in order to avoid the decompensation of the corneal graft, which is still transparent. As we begin the surgery, we notice there's virtually no iris tissue left, there's a capsular phimosis, and capsular support is present 360 degrees around. So we thought that instead of doing a sclerofixation, we would just enlarge this capsular phimosis and then tuck the optic zone of the lens inside the capsular margins, while maintaining the haptics in the sulcus. So a pair of micro scissors are used to cut and raise a small tag of the rhexis margin, and then a microforceps is employed to grab this leaflet and try to propagate it circumferentially. Then another paracentesis is done, and this time we try a bimanual approach to grab the rhexis with one hand and then cut it off with the other hand, making it adequately sized to achieve an optic capture. The capsular remnants are then taken out of the eye, and now the lens is rotated to free up its haptics. After that, with the aid of a blunt spatula and a Sinskey hook, the optic is carefully pushed backwards and is appropriately secured behind the rhexis. Now we use the vitractor probe just to make sure we're gonna be able to evacuate the anterior chamber, as well as to cut and aspirate any potential vitreous material that might have prolapsed anteriorly. We go all around the AC, irrigating and aspirating the OVD. The wounds are sutured with a 10-0 nylon to ensure they are completely sealed up and the knots are buried in the sclera. So this was a quick but rather interesting case, showing that sometimes we gotta keep it simple and do what is in the best patient's interest. As said before, this patient was referred to us to do an IOL fixation. However, we were able to address this case in a much simpler and less invasive way, just by enlarging the capsular phimosis and performing an optic capture. These are some pictures of the first post-op days, showing that the cornea is transparent and the lens is adequately sitting in the right position. The UBM exam done postoperatively shows that the IOL is now nicely secured in place and won't touch the corneal graft endothelium anymore.